today. I'm going to actually talk about two things that we've been doing. I wanted to present this complication because I think it's important as people start this up and go into this for us to be aware of things that can happen and to minimize risk accordingly. And I think this complication represents something that can happen. I think it was a combination of many factors, not just radiofrequency, that contributed, but I think it is important because it highlights a few points, particularly about anesthesia and depth of anesthesia, etc. I also want to just present a little bit at the end too about some of the work we've been doing with nerve monitoring with radiofrequency, really to attest to its safety with regards to the recurrent laryngeal nerves, provided the precautions are taken, and I'll go into that briefly as well. Let me just see. Okay. So this patient, a 72-year-old lady, she had a history of long-standing asthma, fibromyalgia, chronic pain, hypertension, atrial fibrillation, multiple medication allergies. She had a symptomatic thyroid nodule that she had put off surgery for because she was worried about being on thyroid medication after surgical management. She had had other procedures on other body parts, and she warned me that she was part of what she calls the 2% club, with very unusual complications happening after what should be fairly routine procedures. But I took that with a grain of salt, thinking, you know, that patients often classify themselves in certain ways, but she may have been right. Her symptom score was 7, cosmetic score, oh, I'm sorry, that just skipped through that. Cosmetic score 4, her VHI 10 voice handicap index was 5, and interestingly, she pretty much had zeros, so no issues with all of the questions except for the one question, I run out of air when I speak, which she circled the maximal score for. So this was the nodule. It extended into the isthmus, right side, extended into the right isthmus, and benign on a number of prior biopsies. So the procedure was uncomplicated. It was one of the first few cases that I did. The radiofrequency, I actually went very gently on it because, you know, being one of the first few cases, I was, you know, fairly timid, I think, with the ablation. Radiofrequency 30 to 50 watts, 30 watts, you know, 25 to 30 watts near the trachea, and then and posteriorly, and then 50 watts towards the center of the nodule. Total ablation time 10 minutes. Obviously there's stopping and starting for needle repositioning, but the actual ablation time was 10 minutes. I used a 7mm probe size. So at 3 weeks or 3.5 weeks, she was doing great, and she'd had actually a 54.7% volume reduction in the nodule. She felt great, but about a week before I saw her, she started to develop a cough, and associated with upper respiratory tract symptoms. And interestingly, I also developed that cough around the same time, possibly caught it off her, or vice versa. And I must say that it was probably the most severe cough that I've ever had, and it lasted for a good 6 weeks in me, and I'm healthy, and I was very, very unwell with this cough. Was it COVID? We're not sure, but it definitely was a very severe cough. So she developed this cough and these upper respiratory symptoms: blocked nose, nasal congestion, sore throat, and then this profuse cough. And she had severe coughing spells to the point of retching on an ongoing basis for basically, you know, a month after or 3 weeks after mid, you know, 2 weeks after the procedure. It wasn't responsive really to medications. 1 month after the procedure, after she'd been, you know, doing this constant coughing for about 2 weeks, she presented with a tracheal tear, which manifested as an air pocket that moved in and out with respiration under the skin. So we managed this conservatively, but she actually went on to develop pneumonia. She had purulent sputum, she had pleural effusion. So she developed a pretty severe, from a pulmonary point of view, pretty severe pulmonary symptoms. And 2 months after the radiofrequency ablation, she was admitted with shortness of breath, and this was her X-ray at that time. At that time, she was diagnosed with congestive cardiac failure and pulmonary hypertension, and she was medically managed, and she had a gradual improvement actually in her cough and shortness of breath. And once the cough settled down, the tracheal tear, the motion of the skin settled just with direct pressure. So that was all fine. But then subsequently, 5 months after the procedure, she started to develop shortness of breath again. And she was noted on imaging to have short segment tracheal stenosis. And despite a dilation being attempted, she actually had significant tracheomalacia of that segment, meaning that the cartilaginous rings were so floppy that really it was the collapse of the rings, not actual stenosis, that was causing her problems. And so she actually ended up having a short segment tracheal resection due to her shortness of breath. And she's recovering from that now with some unusual complications, which are being managed by her treating team for that surgery. But she's doing well now. But interestingly, at the time of surgery, it wasn't anything pinpoint where the ablation had been. She actually had diffuse malacia of her tracheal rings circumferentially noted at the time of the surgery. So there's a number of, I think, learning lessons. I wanted to mention these. Most of my ablations have been done under general anesthesia. And so there's some question of whether it was done under local, whether she may have felt this more easily. She may have felt something and actually warned, and we would have stopped the procedure. It was a fairly low heat current. The probe was kept fair way away from the tracheal wall. And actually I under ablated that segment and left a rim of tissue around that tracheal wall. And so I think it just represents there is obviously going to be heat transmission, some heat transmission to adjacent structures. We know the nerves, we know, so, trachea being one of those structures. And I think with the right combination of circumstances, as in this case, you could get some weakening of the wall. Now, I think this was an unfortunate case. She developed the upper respiratory infection. She had this severe cough, and then she had probably, in retrospect, possibly some long-standing tracheomalacia. She has autoimmune disease. Interestingly, her post-resection pulmonary function tests are now normal, and the so-called asthma that she always had does not any longer appear to be, present, which is interesting. But and tracheal tears, they've been reported in open thyroid surgery, presumably due to use of cautery or heat devices near the tracheal wall. So definitely precautions to minimize tracheal heat transmission need to be taken in radio frequency. And, probe choice, size of probe is important at low energy settings, maintaining that cuff of unablated tissue over the trachea, similar to what we do in the danger zone for the nerves. And the other thing I think it raises, if people are unfortunate enough to develop a bad cough or cold in that first month post-ablation, maybe need to just, they need to be probably treated fairly aggressively, particularly if the ablation has been of a nodule extending into the isthmus or extending into that peritracheal region. And so that was that case. And Professor Beck, do you want me just to go on and present this next lot of data and then just stop then? Would that be, or do you want to pause now? Because these I've just got a couple of slides on what we're doing with regards to nerve preservation, which I think are worth discussing, also from a risk minimization point of view, but obviously with a different structure in mind. So maybe I'll just go through this and then we can take questions after.
Yeah.
Does that?
Yeah.
Yeah.
Yes, thank you, Sinclair.
Okay.
Your next slide would be very useful, but we have limited time. So the first question is a really important question. Cough might be due to irritation of tracheal mucosa. Do you routinely use antibiotics for paratracheal ablation?
So I do not routinely use antibiotics for ablation, no. In this case, this patient did get started on antibiotics once she developed the cough and upper respiratory symptoms, but no, for a routine ablation, I do not use antibiotics. No, I don't know if anyone else uses antibiotics, whether that's any different for any of the other presenters. No.
Yes, thank you. We also don't use, and cough is a very good question. Cough is an initial sign of tracheal mucosa damage. Therefore, if the patient complained of cough, we should stop immediately. That is why our society suggests local anesthesia rather than general or IV anesthesia.
Interestingly, she didn't have any cough for 3 weeks after, she didn't have any cough at all. So, but I think, I do agree that I think, I think if you are ablating near the trachea, I think there is something to be said for doing it under local anesthesia, perhaps. There's something to be said with regards to the nerves for doing it under general, you know, with the monitoring, but there's definitely something to be said with doing it under local so the patient can, you know, potentially feel that.
Yes, thank you. Next question. Next question is, are you still doing RFA under general anesthesia or now under local anesthesia?
So I give patients the option now. The benefit of doing it under general is that we can monitor their recurrent laryngeal nerves continuously. And as we know, voice is a very poor predictive factor for nerve function. So by monitoring the nerves, I have some singers and actresses, and monitoring their nerves, we can see even very early amplitude declines in their neural function. And luckily our data to date has been very promising in that we have not, even with posterior nodules, we have not observed significant amplitude declines, which is very promising. But I give patients the option and I warn them of the pros and cons of both. This particular lady in the case presentation, she actually was needle phobic as well. So she would not have done she would not have done it under local anesthesia. But yes, so some patients choose general, some choose local. Yeah.
Yes, yeah, I agree. General anesthesia would be better to minimize patient anxiety, but local anesthesia has some advantages over general anesthesia. So you do sharing decision with the patient.
Yes, absolutely.
Okay.
And very, very transparent discussion about the potential pros and cons of both techniques. Yeah.
Yes, I agree. Very nice. Next question is, can you please hear your work on nerve monitoring? Can you?
I'll very briefly go
briefly,
very,
okay.
very
Yeah.
briefly. So basically, in 2016, we developed a technique to monitor the recurrent laryngeal nerves for surgery, non-invasively. But it does require that the patient is under general anesthesia, because we use one of the EMG endotracheal tubes that we use regularly in surgery for nerve monitoring. But the beauty of the technique is that we can actually monitor the function continuously. And so it opens the door for techniques like radiofrequency or transoral surgery, where the nerves are not necessarily on display as they are in open surgery, for us to actually be able to monitor their function continuously without needing to make an incision on the neck or anything. And basically, we've been doing this. I think we've done 20 nodules that we've monitored to date, and pleasingly, I've taken precautions in that I do not ablate within 5 millimeters of that danger zone. So sometimes that does leave unablated tissue there, but you know, so be it. It's a safety thing. But we have not seen significant amplitude declines, which does attest to the safety, I think, of the technique, as long as you do take precautions and use hydrodissection, and then also maintain a cuff of tissue if you are ablating in that danger zone, and ablate perhaps with lower power in that zone.